Okay, so I guess we can start by the time people will also parallelly join. Good afternoon, everyone. I hope I'm audible. If anybody is unable to hear us, you can mention it in the chat. Also, adjust your audio. I'm Varun. I head the hospital success team at Medlearn. Very warm welcome to each one of you in today's discussion. As you are aware, Medlearn hosts a series of industry expert sessions to empower and strengthen the healthcare community through knowledge transfer session. Today, we are privileged to have another expert with us today, one of the renowned faces in quality and compliance management. But before we give you a brief on the speaker's expertise, let us understand a bit about Medlearn on what we are and what we do, and then we can proceed. Subhashi, requesting you to play the Medlearn video for us, please.
Hospitals work round the clock to serve patients. Being at the center of the action, hospital physicians and staff must confront every situation and every challenge. They must also keep up with evolving health needs and knowledge through ongoing comprehensive training programs. What they need is a promising solution to ensure a continuous learning journey.
In today's world, technology is transforming life. Be it taxis, food delivery, everything we need is at our fingertips. Education is also going through a transformation, and we are at the forefront in the healthcare industry.
Medlearn is a comprehensive learning, training and skill development platform incubated at Impulsys in India for healthcare professionals to attain the right mix of content, learning and skills that help them throughout their career. The platform offers a wide variety of courses that enable hospitals to meet their employee training and development needs in areas of quality compliance, soft skills and induction. The platform is designed in a way that it enables easy tracking of the real-time status of their learning progress. What's unique about this platform is that it's accessible anytime, anywhere, ensuring quality learning literally at your fingertips. Hospitals can now assign courses and track the competencies of users on specific topics with Medlearn's intelligent assessment tool, which gives them better administrative control. Its superior courseware helps hospitals provide standardized care and bridge skill gaps at every level in the organization. The healthcare professionals will also become more efficient and empowered when their learning journey progresses with ease and at their convenience. Let us unite to improve healthcare in India by spreading knowledge through technology. Medlearn. Better prepared for better care.
Thank you, Subhashri. So today's session is going to be a bit exciting because Medline is thrilled to launch its sixth edition e-learning program also, which is going to be hosted on our platform. We would be giving you a preview of one of our NABH sixth edition's e-learning courses at the end of this session. So stay tuned. Be with us at the end of this session. Watch the entire session till the end. You will be getting some really important updates and insights from our expert speaker. So the structure of the session, as few of are asking, we're gonna be deep diving into the NABH 6th edition latest update. Post that, we are going to have a Q&A. You can post your queries throughout the session in the chat section, and at the end of the session, we would be taking up the questions. After that, we will take some time to give you a preview of how 6th edition courses as e-learning format are designed by NABH and Medlearn's internal experts, which is going to be showcased by Ms. Vinodini, who is the manager of content strategy at Medlearn. So, giving a brief about our expert today, Miss Anusha, warm welcome to you on behalf of all the participants and Medland team. Thank you so much for agreeing to do this for us.
Thank you so much for.
So, Miss Anusha is a distinguished healthcare quality and patient safety expert with over 15 plus years of experience in healthcare industry, currently serving as a senior manager quality and compliance management at Rela. She has been instrumental in leading the hospital's quality and accreditation program since 2018. Her work span a wide spectrum of compliant domains, including NABH, JCI, NABL. Ms. Anusha holds a nursing degree and diploma in critical care nursing and MBA in healthcare management. She's internationally certified as a professional healthcare quality expert by NAHQ and a certified professional in patient safety by Institute of Healthcare Improvement. With experience at Apollo Hospitals and Gleneagles, she has served in key roles such as JCI Survey Coordinator, NABH, NABL accreditation. She's also an internal assessor for JCI, NABH, and NABL, and a faculty member for CPHQ and CPPS, preparatory courses mentoring healthcare professionals across the country. So it's indeed a privilege to have Ms. Anusha for the session today. Over to you, Ms. Anusha. Before that, I would also like to mention our CEO, Mr. Deepak Sharma, has also joined the session. The entire course curriculum on NABS 6th edition, whatever you see, the course upgrade, everything is under the guidance of our CEO. Deepak, any welcome notes from your end?
Oh, you already said that I don't want to keep the audience waiting, but very, very grateful and honored to be able to host you. I think there's a very a moment that a lot of the hospitals have been waiting for. What is in NABH 6? How do we adapt? What is the additional training? How's the focus shifted? What is both the intent of NABH and what does it mean in terms of change management, not just re-accreditation, but also, in terms of operating thing, because in the accreditation process, I'm sure there's a shift of focus on implementations there, but in terms of operating, what are the best practices? We're all very eagerly looking forward to hear from you, the experts. So thank you so much.
Thanks, Deepak. Over to you, Ms. Anusha.
Yeah, thank you so much, Varun, and thank you so much, Deepak, for adding a little help before we get started. And it's my honor to be part of Medline on today's webinar. Thanks for the opportunity. I'm sure that I'll be making it interesting in the given time given to me. So I'll take it forward. Hope my slides are visible.
Yes, yes.
Yes, it's
Yes,
visible.
perfect. Thank you. So I've taken some bit challenging topic or in one which I have to cover with 45 minutes. That's become challenging because when you talk on NABH, when you talk on quality, that becomes a continuous part which we cannot cover in a time frame, whichever is given. Even if it is 4 days, we can talk on it. But I'll try to make it as simpler and crisper because everyone goes with the gold standard like Gita or Quran, whatever is written in the book, we are following it. I'm going to give you key points where we take up and then take it forward and other things because we have been talking about this edition object for more than 6 months. By the time NABH was given a preview edition launch and booking for another things, we were all really hunting for that. Okay, when it is going to come to us, when are we going to get, and what is there going to be in it? Even the draft has been reviewed, but we are all waiting for the final edition with the new designs and the books and other things to know that what is there really into it. And moving on to today's things, we'll just see grossly on your what mainly sixth edition talks about and what are the changes in standards and objective elements, any new standards and modified standards which we need to focus, some of the new objective elements and little things in your key changes in the interpretations because we cannot look only in your standards and objective elements. There are few things which has been added silently into the interpretation where we need to focus and highlights on your key performance indicators. So that's the plan for the day. So starting with your standards. So another things, chapter number remains the same, standards remains the same as 100. There is no change in it as such. The question here comes about with your elements as such. Number remains the same. Here it is overall, if you could see core, commitment, achievement, and excellence. We all know the meaning behind it. Even though I have just added core is for any assessment starting from your pre-assessment to your final surveillance or whatever it is. Commitment, definitely any organization should abide when it is at your final assessment level. Achievement, somebody is with your surveillance level, and excellence, anybody with your reaccreditation cycles and other things. We all need to abide by those elements of this. Sixth edition totally has 639 elements. Overall, if you could see a little change in your fewer here are numbers. So totally we have only 12 things. So it doesn't mean the number decrease means that NABH have scaled down. But literally from 5th edition to 6th edition, they have scaled up the requirements that what we need actually. So some of the elements of A, B has been like A and B, two elements have been clubbed to form a single element so that we have had a new elements and the new focus where we need to add on other things. So numbers doesn't make okay 12 things are less and we have only lesser work to focus. That's not the intent behind it. Their things have been very clear, so they have modified the things and they made it much more structured where we need to really focus and take it forward. And the major key focus what they have, first one is on the technology. Technology doesn't mean only with your patient processes, even with your diagnostics, even with your data management, everything. They are like enhanced technology in wherever we move in. Any processes, starting from your assessments, your prescriptions, your data management, your incident reporting, can be anything. So audit match, whatever it is, use your technologies wherever. The organization should have your plan for adapting your technology in wherever the possible measures. That's number one. Number two, the focus is little more. See, we are in healthcare talking about a lot of diseases and other things and other things. The focus of little things on managing has little shift. The little additional focus has been given to your preventive and promotive health services. So that means what are we doing? It is not I'm just treating a patient whomever is coming to my hospital and then taking it forward. So it is like what I am doing or postmortem with the things. So am I really doing something? Am I really doing something to contribute to the community? Am I really contributing something to the patients who are visiting me and taking it forward? That is also being stressed upon in the sixth edition. And sustainability. That is the one word which is echoing in healthcare and many of the programs, conference, events, wherever you talk sustainability, green environment, environment friendly, whatever. The sustainability is the word which is hanging over everywhere in most of the events wherever you take up. It can be any programs, events, conference. Without sustainability and technology, we cannot skip any programs nowadays. So that is also being added with little advantage to stress on that it has been put on into the ROM chapter. All right. To start on, we have only two new standards added to the sixth edition. So even the standard number remains the same, 100 and 100. We have only two things which has been added. So first one, so it is on AAC. This is on your, as I said, it is on your preventive and promotive health services are provided in safe and collaborative in a consistent manner. So when you say preventive and promotive healthcare services, that is a very broader things. The elements which has been said is when you say preventive and promotive, they are like it is not only to one specialty. They said if you are in your NABH application, if you are saying you have 60 scopes, if you are saying 40 scopes, or if you are saying only 10 scopes, doesn't matter. Whatever is being defined as a scope for your healthcare organization, for all scopes, this element applies. So that means we need to do something. So anything can be with your lifestyle modifications, anything to do with your counseling, anything to do with your health educations, anything to do with your vaccinations, anything to do with any other services which is applicable to that scope. So you can take it up something for your preventive and promotive care aspect in that particular specialty, or you can extend this little elaborated to your community programs also. So based on your scope, see for example, if you say with your pediatrics, you can say something with your vaccination, something with your growth and development, something with your adolescent care, something with your counselings, uh, which can tailors, or something with your enhanced things like your growth and development, anything you can add on, or you can take up some more programs in your community awareness and other things. This can be extended to any specialties wherever you want, but the focus has to be stressed on based on the number of scopes you have. So each scope, so this you cannot put it down to only one specialty. So this applies to all specialties, all clinical specialties you have in your applications. You have defined as your scope for your NABH application. This you have to go and discuss with all specialty teams, with your medical admin teams, and you have to think what any specialty is doing, what each and every specialty is doing. This point has to be bombarded against all the clinical teams. We cannot restrict to only one specialty. Like I said, for pediatrics, it is applicable to any specialties in the organization. The team has to focus for all the things. Next comes is your evidence-based common terminologies everyone used. It has been combined with evidence-based and contextual age-appropriate screening for non-communicable diseases. NCD becomes a challenging part in healthcare. So NCD is the one which is worrying factor. If you could see, look back and see at 1 or 2 decades prior, it was only communicable diseases. Now the major challenge in healthcare is NCDs. Even the MOH is stressing on your NCDs, lifestyle modifications, your screening, lot of things. Even many of your healthcare settings are focusing on your healthcare screenings, your packages. Everything is stressing on your non-communicable diseases. All your master health, they have a lot of things focusing on your NCDs. But how you do? Are we having some evidence-based practices in rolling out something like that? It can be for your diabetes, it can be for your osteoporosis, it can be for something like simple things like your breast cancer for mom or something. You need to have that's age appropriate. It doesn't start only with age of 40 plus, 30 plus, or whatever it is. You have to have this for any age specific accordingly. You may put it into those things into your master health things or other things. How do you promote and other things? Not only with the patients who is landing up in your clinic, also for something to take back and see how much you are making your public team aware and other things. That also applies for this 11B. And AAC 11C, so mental health has been given importance. So we all know WHO stresses on a complete. So we have just crossed World WHO Day on April 7th, and so many messages have been flooding and going in. Now the thing is like mental health screening. So now who is the ideal candidate? Who's so now we need to know which candidate requires a detailed mental health screening. Again, that is not one by something else. It needs a validated tool. It should be done by a trained and qualified personnel who is doing a mental health screening. It can be a psychologist or can be a person by psychiatrist based on the appropriate need the patient requires. So now we have to know which patient requires a screening and which tool. It is like similarly for adult pediatrics, this problem, XYZ problem, this tools. So we need to identify the age specific problems, scenarios and other things, and the tools which I'm going to use it and who is going to do. So that has to be clear cut defined and we need to take it forward. That's very, very important. And 11D, it is again on evidence based and contextual pediatric and adult immunization. We all know about immunization. We all follow universal immunization program for your pediatrics. That's very good. Followed. It's all been practiced everywhere. Now, even in PHC and other ways, we have following this universal immunization programs. That's been taken care. Now the stress is on your some more of your optional vaccines, additional vaccines, we call it as a catch-up vaccines or something like that, that has to be looked into it, and adult immunization. So adult immunization, so it's not like that thing, young can sit back, see, I'm an adult, I don't want to take vaccine. That's not the case. Maybe you get a seasonal vaccination like a flu, influenza, and other things. So that also has to be there. And a question comes is like, do your organization promote your adult vaccination practices? Is there a service? Is there something a patient has been given a choice to step into your organization and take your adult vaccination programs? And what are your available services? How a public is being made aware? It is like, because this doesn't come only in the standards. If you could link with your AAC 1, where you talks about your clinical specialty scope of services, it has been defined based on your need for your community. So that becomes in your community, you cannot say, I don't have adults. So that is nowhere we can't escape. So we need to have something which is focusing on your vaccinations for your both adult and pediatrics. 11E. 11E talks about your MBT, that is your multidisciplinary approach in your health educations and lifestyle modifications. That means everybody is educating patients. See, a doctor, nurse, physiotherapist, dietitians. I may have a counselor, lactation counselor, physiotherapist, rehabilitation therapist, occupational therapist. I have so many people who's coming into contact with my patient care processes. So then I have to say that who is qualified to do what and who can do in what. It can, especially on your lifestyle. See, for example, a patients with alcoholic and smoking or tobacco habits is coming into your setting, and he or she is into some of the diseases, then which all the points, who can cover, which are your touch points, who is going to cover what are the things. So that means your lifestyle modifications. So how are we going to monitor it? These are the major challenges actually. When you say these are the elements which needs to be done, all your objective elements are subjected for your assessments and scoring. So we need to score that for that. So now how do you evidence this? See, for example, I can, if the assessor walks into the cabin and say that, yeah, we are doing education, I'm doing a cessation education, nobody is going to believe you until unless you have a documented evidence and the practice proof to say that, yes, this has been implemented, this has been practiced, nobody is going to believe us. So we need to look into it. So what are the challenging situations? How can we implement in multidisciplinary setting and how I can evidence it? So that's very, very important. So when you say education, also think on for a little extra measures like with your something with your IEC material, information educations, those things. So it can be in a form of anything. It can be a soft copies, can be a handouts, can be a brochures, can be videos, can be things which you can share it to your patients, to your WhatsApp, Gmails, and other things. What are the modes you are doing? How it is being taken care? Those things are also has to be looked into it. When you call it as a lifestyle, it is touching major areas that has to be looked into it with this new standard. With the another new standard in ROM, so ROM, this is what the management ensures sustainability in hospitals by addressing environment, social, economic factors from long-term well-being of healthcare system and community. This is mainly talks about your ESG. ESG is the one, and so that's being environment, social, and governance. So that's the one which has been spoken many areas. When you say this is environment friendly, so environment at least we'll know, because even fifth edition was little stressing on your what are the things you're doing for your green environment measures or environment friendly measures, something like that, or reducing your carbon footprints or something. So that we can add on to say for your environment things. When you talk about your social, that means what you do for your society. So society doesn't mean only your scope within your health community, it also covers for your employees within your system. So when you call for your employees and other things, it includes your employee well-being, it includes your fair pay systems, adherence to your laws, maybe with your labor laws and other things, that also has to be taken care of. And when you talk about your governance, governance is a bigger term which your top management has played a role into it. So it is like something to do with your clinical governance, something to do with your risk practices, something to do with your ethical practices, your business strategies, and other things. That also has to be looked on for your ROM 3A. Moving on to 3B. 3B is not a new addition. Standard is new, but 3B is an element which was there in FMS of previous fifth edition. That the same thing has been moved into years 3 in ROM. So there is no new addition in fifth and sixth for 3B. And 3C talks about your social responsibility. Little addition to 3A here, the focus is on your little things, what you do for your community in terms of your CSR activities. So even though in previous the CSR has been looked into it, CSR is focused only during your leadership interviews, ROM interviews, like what you do for your CSR, how much it's been taken care, and what is the percentage you're contributing from your hospital revenue and other things. This was like a closed room discussion. Now it has been come into your picture, like what you do really for CSR. So you need to know that your team will say, I have run this, I have run this. Is it really CSR? Not all the activities can be accounted under CSR. So that aspect has to be looked into it. So you try talking with your marketing team or a branding team, whoever takes care of it. So try adding your activities, which has been happening on a monthly basis, into your CSR. So whatever your organization stands for your CSRs, no, it doesn't end only with your free camp, offering some health checks and other things, maybe investigations, maybe during some campaigns and other things, maybe during a World Cancer Day, World Breast Cancer Day, maybe during something you will be having. So you need to collate all those things, what you do really for your CSR activities. And 3D, again, this has been in HRM chapter, it's been moved under ROM chapter, and it's not a new element as such. 3E, it's a new one. It is sustainable procurement practices. Even though we know procurement talks about your vendor selection, vendor approval, and other things, now comes is a sustainability in your procurement. It is like, it's not like my purchase team is, procurement team is going to buy me something and I'm going to use something. Even though that's a practice, here comes is like, they are bringing you a lot of, see, let us take something for an example, like they are getting you some lot of disinfection materials and other things, or they are getting you some paints and other things. Is it environment friendly? Are they getting in that angle? That is what looked upon here. So I have to get something in terms of your overall standard. It's on with your overall. It is also cost and other things. Maybe in paints, it is low VOC paints. So now something your purchase team also have to contribute. At any given point of time, you should have an answer from your team saying that these are the one we are taking it for an environment friendly measures. These are the products I'm getting into it. That is the area for focus. 3F, it is like it's very beautiful point actually. So even still it's a debating among all my colleagues and other things how to get it implemented. It is like ESG doesn't stop only with your organization. ESG also, when you say social, we say that yes, it doesn't talks only with your community, it also talks for your employees. So your green efficiency, your environmental measures has been extended to your employees, like how best you are encouraging your employees to be part of these measures. Maybe like a carpooling, maybe like it is like how organization can promote it, that becomes a bigger debatable part in multiple areas till now, that people are having different ideas. If you have your services provided from your organization by picking people from a common locations, I think that can stand as one of the example. If not, that becomes still challenging point to implement it by any institution. And last one, 3G talks about your financial sustainability by balancing your financial aspects. So when you talk about your financial sustainability, it is like your long-term aspects. So in terms of your effective resource utilization, ethical principles and other things, that will be looked on in your 3G. So that's with the two new standards has been added, and wherever it is all been like your things have been clubbed, modified, little things has been added into it. So other things are things. So in that we will see. So moving on to AAC 7C, the one, it is 7C, it talks about your laboratory quality assurance program that's been there for long ages. No, there's no change in it, but the addition to it is equals and proficiency testing, which is a common terminology used for NABL audit. Nowhere until fifth edition, this has not been stressed as a requirement in NABH standards. Only for NABL labs that's been focused. If your hospital is not having an NABL accredited lab facility, then this needs to be for your center has to register for your equals of all the components, whatever they are doing it, and then they have to go for that equals and proficiency testing. So, so wherever there is equals is not available, then we have to explore for your proficiency testing practices. And AC12F, that's on your domiciliary care. So this has not been there in fifth, it's a new element actually here. It is your domiciliary care. It is simply on your ambulatory and your home care services. So that means I am doing services at the home. So who can do? It can be your doctors, it can be your nurses, it can be a physiotherapist, it can be your occupational therapist. So I have to define that who are trained, because it should be part of their training, it should be part of their activity as such. If I'm sending a physiotherapy for home care, whether he or she is trained and qualified to do a home physiotherapy services, so you have to put it into part of their competency and your privileging that has to be looked into it. Because when you say trained and qualified people, how will you say trained and qualified people? That becomes the ultimate requirements to prove that how they are trained and qualified. So that also need to be, and in your policy just add on that which are the services you have under domiciliary care. So that has to be done into it. And what are the, at least you have to minimize little limitations like the activities, but are not limited to, at least try listing out few things. This I take it in a domiciliary care. And comes with your 8B. 8B, it talks about your, it was there actually initially. So now it is, the focus is on your organization has defined and implemented. That means your policy should be there and implemented for your blood collection, testing, storage, distribution. So previously it is we are stressing only on your clinical practices, like how a blood is being brought from a blood bank, transfused to a patient, monitored, pre-transfusion, during transfusion, post-transfusion, other things. Only that was the focus now. So now it has been extended. If your center is already accredited with NABH for blood center, this becomes an easier task. If not, the policy has to be defined. So they have given the details for what needs to be focused, when needs to be focused, that needs to be taken care. When you say it is from the collection, prior you are going to look in for your donor selection, donor verification, your collection process, your testing of for your TTIs and other things, storage, again and storage, it is like your storage from the collection. So how they, before testing, how the product is being quarantined, stored, then tested and then put on into your issue. So then becomes their distribution. So all these things, if your collections, if your center is having a larger blood centers and other things, if you're focusing on your stem cell collection, apheresis collections and other things, that also has to be looked on into your policy details, and the same has to be implemented in your practices for your thing. And 8C. So now the question is, the components are stored safely from collection till transfusion. So if you're in your hospital, if you're collecting a blood product, yes, I'm collecting, stored into the fridge or whatever the temperature requirements, it's been taken care. Imagining that your blood center is going for a camp outside your organization and coming back the product to your center. So then it becomes a challenging point, like product is transferred from XYZ location to your location. So in that area, whether the temperature is being maintained. If you say is maintained, how it is maintained, what is the evidence to prove? You need to have a data logger connected to the box whichever you're using, and then it should have your report generator to say that product in, product out, this is the temperature time. So I should have it and other things. And little things talks about your product identification, your product labeling, that is your product unique code. It is like a patient has your UHID number, product also will be given a code. So whether your product identification, donor identification, all these things are also will be looked in for your A, B, and C. And 8D, 8D, we all know, we all talk about your rational use of products. When you say it is rational, it is a right product goes to a right patients to a really a patient in need. So clinically it's justified, prescribed, that is a rational prescription with the clear-cut indications, and then product has been given to a patient. So that is what is your rational use of your blood and blood products that will be looked upon to it. It is from the time order to the transfusion, everything is being there and the process has been listed and taken care. And some more thing to add on. Yes, 10E, it is on a birth companion. That becomes a fancy practice in most of the corporates actually. So always we allow somebody inside the labor room and then take care. This has become a trend and practice with so many things into the system. But now the focus is on how your organization is enhancing those practices. So now I say, okay, default, it doesn't mean that my husband is allowed, my partner is allowed, or my mother is allowed, or XYZ person is allowed. So now the plan starts very early. Am I identifying with birth companion for this expected mother in the maybe in terms of your last pregnancy, last trimester and other things, birth companion is identified. How do I prepare my birth companion? It is like, see, yes, I know it's my partner, they are happy. So are they prepared to face the labor rooms? Maybe with a little labor room exercise, telling them how the delivery process will be there, pros and cons. It like, okay, a husband is coming, standing there, seeing the bloods and other things. If he faints, that becomes a funny experience. And that becomes another panic situations during the real time labor. So how do we prepare? So even government has given a beautiful guidelines that's been posted as a reference in NABH itself. So how do we identify them? How do we prepare them? How do you make them stable during a labor and delivery process? That becomes a requirements of 10E. So moving on to 10F. So it is like your respect for your pregnant woman and the companion. So labor room is the commonest area where we can see that language and other things people will be using here, hey, why, and other things. So it is like their respect is also has to be taken care. So even though it is one of the patient rights, it's been stressed under your COP 10 where you have your obstetric services. We need to be treated respectfully. So that's very, very important. We cannot say like, oh, even in that, even though we'll say that, okay, it has been done for the purpose of baby and mother, not allowed. In any extremes, mother and the companion has to be respected. And privacy. We know that yes, it is going to happen. Okay, it's nearing term and other things. So ensure privacy at most as possible. Don't expose unnecessarily. That's very, very important in comes. When it comes for labor and delivery, we all think it is normal. But to that, it becomes in panicking situations for them. They may not feel comfortable, but they won't express because at that time, everybody will be in a different situation and the mindset when we go through it. So those things has to be looked upon. And 10G talks about explain the danger signs and important care activities to pregnant mothers and companion. It is like how do you tell the patients like when and how to obtain their urgent care and part of your discharge summary. I need to prepare my pregnant mothers, expectant mothers well in advance for your following signs and symptoms. Observe for your fetal movements. Come to your labor room whenever you find your um, fluid leakage, or when you find there is a show of blood, and I think something we need to tell the mothers and other things. So that is being have to be told to the mother as well as the companion whom we have identified. That has to be instructed well in advance. These all has to be taken as a series of training. If you have a well structured antenatal program, training classes and other things, that is your birth classes and other things can be taken. Some or the other ways we have to identify the way of putting it to the companion and the mother as well. And 10K. So with the challenges, so many newses here and there happening on your ART practices, that is your assisted reproductive techniques. So now NABH also added. So until then it was your obstetric services, including reproductive medicine, your reproductive medicine, that was the things. Now this has been there. If your center is applying for the scope of a reproductive medicine, you have to first thing abide by the laws and regulations that by the government, that is based on the gazette notifications of your ART Act and the Surrogacy Act if your center is having surrogacy, from the time of license to the persons, that is licensure, to the personal employed, to the facilities like your infrastructures, labs, personal, handling, and everything has to be looked onto it. That is a very big requirement, but even though it's a one element, that becomes a very big requirement when it comes for your ART practices in your center. And 11H, it talks about your adolescent care. It comes under your pediatrics. So with your 10 talks about your obstetric services, 11 talks about your pediatrics. When it comes for your pediatrics, adolescence is a in between age. So we all know adolescent age, how it is. So in adolescent age, we have to talk something on your need-based, preventive, curative, and your counseling services. When you say this, yes. So now it is like your mental health screening, your counseling, maybe for your premarital counseling, marital counseling, your immunizations, all other things has to be looked on for it. And if your center is having pediatrics, you cannot get escaped from your adolescent care. So even it comes for an adolescent age, now the challenge comes between your pediatricians and your adults. So who is going to take care of it? So which specialty they are into it? They are into interim periods and ages. So those things, they may be in height and weight should exist. This also has to be an aspect which needs to be looked in for it. And then PRM 5J. Moving on to PRM 5J, it talks about your patient engagement. How do you engage my patients actively into the care processes? So it is like what I do for them. So how do I get it? So it talks about your support groups and your advisory council. These are two examples which has been enlisted in an NABH standards. So it is like you may have your support group. So maybe I have a support group for your transplant patients. I have a support group for dialysis. I have a support group for cancer survivors. I have a support group for this and other things. Maybe support groups. So if you say that I have support groups, then you have to look into it, how much that support group is actively taking part in your decision making with your care management process and other things. So that's why the beautiful terminology came up for us, like your patient advisory council. So that means patients have been actively part of it. Patients who are survivors or patients who are into that has been actively made part of it to voice out their concerns, voice out their needs, what they want for your patient care processes, and then do it. So we have to encourage patient engagement. So how do we encourage? These two are the examples. If you have any other best practices, taken care, but you need to have something for encouraging your patient engagement process in your organization. Hence, the slide is there repeated. Yeah, PSQ 2D, it talks about your, it's a new one. It talks about your, mainly talks about your quality and patient safety program. Here it talks about something called as your quality improvement program should focus on your appropriateness of clinical care. See, for everybody, doctor becomes a god. So whether the doctor is doing right or bad, we don't know. So now we have to look into in a different angle in a way to say that is it appropriate? See, is my patient given an appropriate medication? Patient given an appropriate hospital stay? Patient given an appropriate things. So in that angle, it needs to be looked onto it. It is basically an utilization review of the services with your drugs, maybe with your regimen, your treatment protocols and other things. Is it appropriate to that patient? Is it underdoing or overdoing? In that angle, it needs to be looked onto it. It's a completely a new element to say that it is going in a right angle. It is similarly It is not like a peer review, but it has a lot of focus to say that is it appropriate? It needs to be clear ethically, it needs to be looked into to say that yes, it's not to do with something. It is not like one doctor is giving load of investigation, other is not giving. That is also one thing. So it is mainly talks about your utilization reviews, can be with your allos, can be with your medicines and other things, has to be looked on for it. And 4B, again, it talks about your quality improvement project was there in 5th edition as well. It's not a new requirement. Here, the added thing is your quality improvement project should focus on your cost and efficiency process in your patient care delivery. When you say it focuses on your cost and efficiency, number one. Number two, it focuses on which domains of your healthcare quality. So it is like your safety, timeliness, effectiveness, efficiency, equity, or patient center. We simply call it as a STEEP, ST, triple E, and P, so that we have to look into to say that all this has been looked into or not. Which aspect is really coming? If you are not covering, if you have been very generic, it has to affect at least, it has to show some efficiency in other some of the domains. If not, your quality improvement projects is not making a real difference. And ROM, one more new element, it has been added to the ROM, that is on a clinical governance framework. So something to add on a little higher weightage for the clinicians and the clinical practices happening in your organization. The main focus is on your patient safety, medication safety, clinical audits, your clinical pathways, your clinical indicators, educations and research, which is what is happening in your institute. Everything has to be looked into your clinical governance framework. When you say this has been your clinical governance frameworks have to look into it, then we have to look into say that how I am going to evidence it. Leadership oversees it. Which level of leadership oversees it? How it has been overseen? What is the structured way of reviewing it? How it has to be evidence? That's level of decision has to be taken place at the organization level. Some of the other things to click on for it is your security manual. It is like in your security manual, you have to add on for which level of access to your hospital has to be looked into it, like your restricted access. That was little given. So now it is like your vulnerable access, which has a security threat and other things. You have to identify in your organization that has to be documented in your manual and measures taken. And 7B, it is your management of your non-fire emergencies. It's been there as one element. Now it has been given as a separate element. It is like organization has a plan to manage your fire and non-fire emergencies. It was not like a policy, different requirements and things. Now you have to define how do you manage it. It also accounts for your disasters. It also accounts for your other types of your codes in your organizations. You have to identify, clearly define your members, roles of your members, how do the process handles, and that has to be defined. And 3J talks about your staff training on your IMS. That is simply, it is on your EMR, your usage, your level of accessibility, your IT securities with your basic passwords, protections, hierarchies, and other things has to be stressed into your staff training. And HRM 9A talks about your occupational health hazard. That is simply on your safety in your workplace during all shifts. That is, we cannot say, okay, morning duty, I will be doing this, evening, night duty is not possible. So employee safety has to be looked into with 24/7. And new stress is on your second victim program. Second victim is a beautiful practice. It is like, see, I'm a person who has committed a mistake because of that patient has landed up in some adverse event, maybe sentinel event if that is the case. So that means I myself will be undergoing a stress and other things. So I'm a victim here. First victim is a patient. Second victim is that me, the person who is involved in making an error because of the patient had an harm. So how this person is being taken care and how organization is supporting for that person to coming out of that pressure to come back to the normal routines. That's what is has to be looked into your second victim program. And some of the other things on IMS 1H, this is on your organization takes enough measures to enhance digital health technology adaptations in their healthcare setting. So that means you can take with your laboratories, you can take with your EMR, you can take with your prescriptions, you can take with your incident reporting, you can take with your audit management, you can take with learning managements, anything. Choices is up to the organizations, but we need to have the way moving forward from the organization towards your digital technology. And 5C, little additional focus is on your data and security. the thing is on your cyber security. Cyber security, it was like data security, confidentiality, integrity. This was the terminology being used. Here in the intent, they have added the focus should be on the cyber security as well. And some of the keywords which you guys have to focus on your something added in the interpretation here and there without our knowledge on the elements or the objective elements or the standard, something which is being given in the essays in between the books. It is to say that AAC 2A, it says scope of the general consent. We take general consent for all patients at the time of admission. So now we have to say this general consent applies for what? You have to define your general consent scope for both IP setting and OP setting and say the limitations of the general consent. 2E, it says that patients who is visiting OPD, we need to prioritize access. So which patients has to be prioritized, that's been defined. So here it is like how others will identify, maybe in a form of visual signage, stickers, labels, and other things that needs to be defined by the organization. 4B, your initial assessment details stressed on including all these aspects, psychological, spiritual, cultural, socio-economic aspect has to be included. 5E, that is on your early warning system that has been already there, but it has been added into the intent to saying that if your hospital is monitoring early warning system, how are you monitoring it is effective in implementing or not? And 7A, it talks on little on your POCT. POCT becomes a gray area. If your hospital is already NABL, that system will be placed. If not, this needs to be looked into it. Like POCT start with your simple glucometer, your ABG machines, your drop Ts and other things, maybe it's different POCTs, ABG machines, or whatever it is there in your based on your setting, needs to be looked on for the measures and a quality assurance program. And imaging quality assurance, they have added for your nuclear medicine, which was not there in the earlier things. And in COPs, they have added clinical pathways was there, but it was not said how many you should have. Now it is said 2 clinical pathways per year, and it needs to be reviewed and updated. It is not like I have defined something and I'm following the same for 5 years, 10 years. It is not acceptable. And 14E, it talks about little on your operative notes. So that was there as an element. Here the content stays, your operative note should include your surgeons, assistant surgeons, anesthetist, assistant anesthetist, your key findings, your steps of your procedure, peri-operative complications and other things should be part of the operative notes. And 15B, organ transplant was earlier there. Here they said they need organ transplant guidelines. Now this time they said it should be organ specific transplant guidelines. If your organization has 6 or 7 transplant, including a solid organ transplant and tissue transplant like a BMT or a stem cell transplantation, you need to have a guideline separately for each and every transplant program which is there in your organization. And MOM 1B, medication safety officer, is being added under the PTC committee. So medication safety officer has to be a member of the committee. So a requirement is a doctor or a nurse or a pharmacist can become a medication safety officer who has a knowledge in all the aspects of your medication safety program. And JD of the medication safety officer has to be defined. And that's coming in HRM and RYM. So you need to have a JD for medication safety officer. 3B stresses on your stock verification audit. It says that organization defines a frequency and does a stock verification audits in all its location. MOM 6F talks about your return of medication was already been discussed, but becomes a challenging is like whether the organization accept return if there is being sold from your retail OP pharmacy and other things. Do we accept or don't accept? Make it public and make your patients aware and do measures accordingly. And MOM 9, it has been previously talking only on your chemotherapy and psychotropic drugs. Now this radiopharmaceutical terminology has been added in the standard as well as in all objective elements. And 7B, PRM 7B, there is something for your patient measures and other things. So now the focus is on your PREM, that is your patient reported outcome measures your organization is monitoring. We need to have evidence for that. 3E and 3F stresses on your antimicrobial usage, that is on your practices, your prescription guidelines, and your strict AMS program. And how are we monitoring it? It has not been given as a mandatory indicator, but if you see your 6th edition annexure, that has a lot of detailed indicators, more than nearly 20 plus indicators, which needs to be monitored. And 6F adds for your monitoring the effectiveness of your housekeeping services. That is, how do we monitor the effectiveness of the environmental cleaning, maybe with your glow gems, maybe with your staff surveys, feedbacks, evaluation, audits, and other things that needs to be defined and needs to be followed up. And other things 2E on PSQ 2E, it talks about the person who is identified as the head of the quality and patient safety program need to be trained in NABH POI. 3A talks about clinical indicators, which has been new addition to it. And 5A, little change in the clinical audit, which was a challenging, painful area for every organization. Previously, it was clinical audit per year, per specialty or scope. Now it is clinical audit for 2 years per scope. And then HRM 5E, it has a training on your cardiopulmonary resuscitation. In intern, it has been given focus for your, in addition to BLS, ACLS, now ATLS and PALS and a neonatal resuscitation program has been added. And AMS training has been added as a requirement for infection control training. And electronic training records, that is wherever we are following, that is acceptable because now most of e-learning modules and other things are there. And IMS 4H, there were a lot of debates like, can we take e-signatures and discharge summary and do it or not, or do we need to have only manual signature? That's been added as a clarity. We can have e-signatures. And 5D, this is a big challenging, painful area that is like data which is generated from your equipments has been addressed mainly in terms because equipments, if you see biomedical equipments, you have your endoscopy machines, you have my echo machines, I have my any of a diagnostic, maybe like a PFT, EEG, and other things. These are the different machines has different software, and where are those data getting stored? That also belongs to my patient's data, whether your organization is having a control over it or not. PACS is everywhere in your organization, but PACS comes only for your radiology and your nuclear medicine imaging. What about the other investigation which is happening in your organization? Which platform is storing and how your organization has control over it? And then 7A, it talks about, yeah, that is a medical record review. That's simply on your medical record audit. If your organization has EMR, you should also have a sample record auditor in your EMR entries as well, because all of a sudden we should not land up in a shock saying that something has been missing over there. And little thing to add on to your KPIs, NABH has given 32 mandatory indicators, perfect. And one new addition in your KPI is in this 32, that is your last KPI, that is your percentage of a safe and rational prescription, which your clinical pharmacist has to do with. This is applicable only in OP things. Your clinical pharmacist have to add on this to this as a part of their prescription audit. And clinical indicators, they have given 18 clinical indicators in total. So based on the specialties, so only 4 is being given as an optional one. That means you can even may or may not have it. Other than that mandatory ones, if that is there part of your application as scope of services, you need to have this indicator mandatory with no other options. And when to implement, we are in April. So already the buffer period of Jan to March is over. So that means any type of audit, whatever you are into it, we have to think only for 6th edition. We don't have any other time to look back and say that we can implement later. So that's the thing. Some of the messages from me is like, there are somewhere it been given as an addition for your PSQ chapters. We can have your quality and patient safety champions like your link nurses and other things. You may have something define a JD. They can be added as to make your quality and patient safety program much more stronger in your organization. Try looking into your self-assessment things. We know that where are we lacking in our own organization, and make your challenges for your 6th edition, and looking for some of the new policy requirements, amendments, whichever required. Maybe I said something like prioritizing patient access, that is there, but how to identify this may not be listed in your policy. So now we need to identify where are the things I need to modify and amend my documents and other things. And if you have open into your NABH 6th edition portal, I can say it is almost 85% same like 5th edition requirements, but there are 15 thing or 10% little higher than what has been required for your 5th edition applications. So those things I have to get ready before I look in for it, and start reading your NABH 6th edition book once again. It's not only once again. How many times you read it, you will learn more and more. And sustainability measures is the one which you cannot do overnight and make it. So that needs to be really pulled up from the time you start preparing for your accreditations and your digital technologies that you cannot escape. So that's from me. Any questions and other things? Hope I have taken 5 minutes extra than the time given to me. Hope the Medland team is not angry on me.
Anusha, thank you so much. I guess you were able to cater everything exact in the given time. So we would be opening the Q&A. I request everybody. So we have disabled audio and video for all the participants to minimize interruption. So by the time we are moving to the preview of our NABH e-learning program, I request everybody to type their queries in the meantime in the comment section, and we would be taking up the queries. So before we go to the Q&A, I request Miss Vinodini. Anusha, we would be requiring some time as we are giving a preview
I'll
of
be
the
staying connected.
Sure, thank you. So, Ms. Vinodini is the manager of our content strategy, has been working on the upgrade of our e-learning program. As you all are aware that Medlearn host nursing, soft skills, behavioral, and NABH programs on platform. So, we would be launching our NABH 6th edition entire curriculum with pre-test, post-test, all assessments, e-learning course modules on Medlearn platform. So Miss Vinodini is going to give you a quick highlight of how a course look like on platform, and post that we can proceed to the Q&A. Vinodini, over to you.
Hello everyone, I'm Vinodni, Manager Content Strategy, Medlearn. So I'll give you a quick refresher update on NABH 5th to 6th migration, the major key highlights. So which will add on and sum up the Anusha session. So the chapters and the standards, which remains the same, which is also discussed by Anusha, and the number of objective elements is from 651 to 639. And so next, I would like to go on the key changes on the broader aspect from NABH 5th to 6th edition. So NABH 6th edition places a stronger focus on the adoption of digital health technologies. That is basically to enhance uh, protocol on clinical and patient care management. And the hospitals are basically, after this 6th edition, encouraged to integrate digital solution to their operations and to enhance the healthcare delivery. And coming to the patient safety protocol, infection prevention control, there's a greater focus, because that initially it was only on the control measures. Now they have mainly focused on the infection prevention aspects also, medication waste management, and overall patient safety. And the hospitals, the recent standard aim to align the hospital with the global best practices, and with the patient-centered care, the patient rights, informed consent, and active involvement in the care decision. So basically, patients are involved in shared decision making, which is emphasized in PRE and even in COP for the birth companion. All the standards which Anusha's described about these standards. And the next one is on continuous quality improvement, strengthening the focus on continuous quality improvement, robust monitoring, evolution, and feedback mechanism. So I would like to touch on the implementation timeline, because to give clarity for the new applicants, existing accredited hospitals which have 5th edition, and the surveillance assessment. So for the new additions, for the new applicants from January 2025, all the new accreditation applications assessed under the 6th edition standards, and existing accredited hospitals which are which are in anyways 5th edition. So during the next succeeding visit, that is next assessment, so the transition to the 6th edition standard should be evidence. This is the basic criteria given by the NABH. And surveillance assessment. So till March 2025, March 31st, 2025, assessments under 5th edition were continued. And this time period was given to just to provide hospitals with the time to adjust with the new requirement. So I think Anusha has given a broader impact on the new additions, objective elements. I'm just giving the outline. So just a minute. So emphasized on preventive and promotive care, that which is on AAC 11. So which is on mental age appropriate screening, mental health screening, all those aspects are covered, and focus on organization sustainability program, which is addressed in RM 3, and emphasize on patient experience and feedback, which is in patient rights and responsibilities, where patients are given greater shared decision making, and for and for informed consent, and even in the danger signs in case of pregnant, birth companion, everything is explained in prior. So patient rights and responsibilities are taken into more concern. And integration of digital healthcare technologies are for patient uh, are for like patient to improve the patient care outcome, and inclusion of specific standards for home healthcare and adolescents friendly hospitals are also included or given more impact, and increased emphasis on medication safety. And when we take on the modification, the broader outline, there are addition of terms and changes of terms, like basically HIC is converted to IPC, that is infection prevention control, and overall the chapter, the medication usage term is replaced with the medication management, and even in our own chapter, management is replaced with the leadership. So all these are the change and addition of terms in the sixth edition. And there are series of objective elements of club. That is, for example, in lab and radiology, about the quality and safety, it is basically club. And certain objective element series are juggled off. And and some objective elements which are outdated or also have been removed off. So coming to the second part, that is Medlearn's e-learning module. So I will now showcase you on e-learning module, which has got Medlearn's e-learning module, which has got a case study or a scenario breakup, pre-test, post-test, followed by a for a new objective element, and also for the existing one. So I would also like to highlight Medlearn is the only organization in India which has got an entire curriculum ready for e-learning module with pre-test, post-test, case scenario breakup for the entire NABH 6th edition. So we are the only one which have digital assessment format also available for employees to see their own growth and at their own pace, like even as a department, and employees can do it at their own pace also. That is through the digital assessment formats. So anybody who is in Medlearn, anybody who's a Medlearn customer or user will have access to all the 6th edition courses. So I'll just take you to this course curriculum. So this, just give me. So this is the Medlearn curriculum of NABH 6th edition for 1 minute for NABH 6th edition in the Medlearn library. So what you can expect is that these are the objective elements which you can expect in the course, like important information, welcome, an introduction, details, learning objectives, and the pre-test activity owner standards, and the broader aspects of the objective elements and scenario, summary, additional information. So I'll just take you to the course. So you can just have the look of the course. So it comes with a short video to have the context of the entire course. Followed by learning objectives. Like by the end of the course, what are the key takeaways from the the particular session. And the pre-test. So here, pre-test, you can actually, there are 15 questions in the pre-test and post-test, and you can select literally each one. So, and I'll show you how it works. I'll just randomly select some questions, and you can see your score in the pre-test. So I'm just randomly selecting. So once the pre-test questions are completed, you can submit the test and you can access your score even. So this is a pre-test score, and followed by the activity owners who enroll or involved in a particular standard. The standard compliance of now, which we see is IPC 3, which has got 3F. So we will see each objective element one by one. Adherence. First one is on adherence to safety precautions. So the you can expect interpretation of the course and the description, followed by list of standard precaution across the healthcare setting, and the evidence for the particular evidence for compliance for the particular objective element. Sorry. So this is 3B, which is adherence to hand hygiene. So the course goes like this: interpretation, description, 5 moments of hand wash, details on hand wash procedures and surgical hand scrubbing procedures, hand wash techniques. This is just an outline of the course, how it looks. So 3C is on adherence to transmission-based precaution. So this is guidelines for the isolation procedures. So next is on 3D safe injection and infusion practices. So 3E is on antimicrobial policy. Initially it was antibiotic policy, now it is like antimicrobial policy. And the very important aspect of which is 3F, which is antibiotic stewardship program. So it goes on like this: the implementation of antibiotic stewardship program. So you can expect also a scenario where a scenario will be discussed and followed by you will be, sorry, you can have a scenario breakup, like you according to the scenario you can select. This will basically help you in audit times, like whether it is compliant, non-compliant, partially compliant, and you can select it actually, and you can select the rationale and where you will get the rationale for each one of the scenario breakup. So next one is summary, a detailed summary of the complete IPC 3 standard. Additional information which has got glossary, abbreviation details, and all the references which the course has been taken from, and the keywords. So after which you can attend the post test. Just wait for a minute. So it's getting load. Yeah. So you can, after this, attending the course, you can check your own knowledge impact of the course, how much is the thing. So you can attend the post test. So I literally show you how the post test and how you can assess your growth or the knowledge impact in the course. This is a digital assessment format which only Medland has in the entire sector. So after you attend the post test, you can expect this. That is, you can view your results, like what you have selected, your selection, and what is the answer and what is the rationale for it. So this is for the entire 15 questions which you have attended. So, and after this, after which you can check your own course details, which I'll show you as a sample now. Just hold on for a minute. Yeah. Yeah. Here you can go to the dashboard and see your progress and results. Like each course has got 3 attempts completely. So in the first attempt, what is the pre-test score and the post-test score, and the second attempt and the third attempt, vice versa. And you can also even download your certificate, which I'll show you as a sample now, after attending the course. And you don't have to have a separate attendance sheet. All the training records. Let me show the attendance sheet. So basically, this is a sample completion of a course. Like basic, here the Medland logo will become, here the hospital's logo with all the details will be coming on. So this is how you can see your own growth, and even if it is a classroom session, you can assess for two or I mean, even if it is a large session of people, 50 people, you can track their performance based on the pre and post like pre and post results, pre and post scoring results. And now I'll show you one such course, which is new edition, a sample for. So AC12F is details on the domestic health, home healthcare visits. So this is how all the NABH 6 edition new courses looks on. This gives detail on interpretation of the objective element, description, which has got policies and procedures. So initially, all the policies whichever is required are detailed on, and the implementation procedures also are also laid down, and each key roles and responsibilities of the person involved in these objective element is described for. And here, of all the new courses, we have added one more criteria, that is practical examples in the hospital setting. For example, chronic disease management program, what has to be done in post discharge follow-up care, how some hospitals have already successfully implemented. These are the practical examples how you can implement this standard in your hospital, and evidence for compliance. So this is the broader details on the new edition. And so I would also like you to show one more course, which is on ROM, which speaks on organization sustainability program in terms of environmental, social, and governance. So the course goes on like this: interpretation, which describes environmental sustainability, social sustainability, governance sustainability, and description on the policies and procedures for each of the criteria, and for all the new standards we have highlighted on the key roles and responsibilities for each of the members involved. And again, the practical examples in the hospital setup for each criteria, for each ESG criteria is described for, and evidence for the compliance for the particular objective element is mentioned. So this is this sample for uh, an existing course and the new edition. Sorry. So
Perfect.
1
Vinodi,
minute.
thank you so much.
Yeah,
Yeah,
I would
yeah,
also
Vinodi, any
like to
point?
highlight on. Just give me a minute.
Vinodini, your voice is breaking.
Yeah, just give me.
Vinodini, can you come again?
Yeah.
Hello.
So this is a review of our existing course and also a new edition course which I showed on home healthcare and ROM standard. So I would like to give insights on why choosing our Medlearn's e-learning platform, learn anywhere, anytime. That is to even in mobile, laptop, or your desktop, and it at any pace wherever. If you have scheduled with any routine work in the hospital, you can do it in your own pace. That is a major benefit of our platform. And which is self-paced training and interactive content, engage with the hospital based scenario. We have got a detailed scenario for each and all. We have 100 object standards, which for all the 100 standards, we have got each scenario and scenario breakup, which will greatly help you in the audit for describing what is compliant, non-compliant, and partially compliant, and which is cost effective. This e-learning platform is also very cost effective and train multiple staff members without travel or accommodation expenses, and continuous updates. You can receive the latest NABH interpretations and best practices also in the further. You can expect always continuous updates on those, and performance tracking. All staffs monitor staff progress and assessment results. You don't have to maintain a separate attendance sheet. Also, it will be automatically coming in the app, and you can have all the details of the particular department on what in all aspect it is covered. For example, all the aspects on HRM 4, 5, 6 is completely on the training, and it also emphasizes on the digital training to adapt to the digital training and maintenance of all the tracking also in the digital training in the NABH edition. So that's it from me. So thank you. Happy learning. Thank you.
Thank you, Vinodini. So those who are asking for the recording, we would be sharing the recording for the today's session on our YouTube. You can check the link. We would be sending the link to the participants also. Number two, you can reach out to us for any queries at info@medlearn.com. Subhashi would be putting the details of the email address on the chat section. You can refer to us. You can reach out to us if you want a preview. Vinodini and her team would be more than happy to address to any queries and concern. On the implementation part, of course, we handhold the existing Medlearn users. But any external member who has joined today can reach out to us. We will be happy to give you the preview of the courses and how consultation at Medlearn works. You can also follow us on our LinkedIn. There also we would be putting the recording. We would be putting the details of all the upcoming webinars. So our upcoming webinars on quality will be based around clinical audits, patient safety. So we would be breaking down each update, every segment, and giving you a complete overview. And so this NABH series is going to continue. So I request people who have joined today in such good numbers to continue attending the sessions. Quickly going to the Q&A, we will take like 5 more minutes to just have the queries addressed in interest of time. uh, those who have asked for the certificates, yes, on Medlearn, certificates also can be enabled. All assessments, pre-test, post-test, feedback, evaluation, training needs, course assignment, entire training cycle you can do on Medlearn. So the platform is very user-friendly. You can do it on your mobile phone also. Uh, so, Ms. Anusha, there's one question that one of the hospital is going for their third on-site NABH assessment. What are the important criteria they need to focus on the sixth edition?
No, if they are going for a third, so that means all the standards and elements are applicable. So we have crossed the deadline. So any assessment which is going to be beyond April, that is completely all standards and elements are applicable. We cannot go with any escape. So key challenges will I'll stress for your sustainability measures. I will say some of the things they are doing with your pediatric and obstetrics practices, if that is in the scope, because focusing on the needs which they have stressed for pediatrics and obstetrics, and do with your clinical audits becomes a painful area, even though from the fifth edition is joints, that we should be looking at pathways. And then something with your digital technologies, adaptions, and its data integrity and data security, that has been stressed a lot. So this, I feel it as a top priority and painful areas for any organization.
Okay. Another question is, as you talked about prescription appropriateness, is there
Yes.
any checklist to be followed?
Now, actually, if you look into the MOM standard itself, they have described on the elements which needs to be part of the prescription audit, which talks about your drug-drug interaction, duplications in those things, food drug interactions, those things, your legality, therapeutic dose, and other things has been stressed upon. And they have added some 3-4 key elements which needs to be stressed on as per sixth edition. And the beauty of this, which is not told in fifth and sixth, is that you need to focus that before dispensing medications. That means you need to have it as a live audit. You cannot do a postmortem audit. It is not a retrospective audit. It is a live audit which needs to be done before dispensing medications to the patients. If your EMR is very good enough, you can have your CP team looking into your indents which comes into it and then have it. If not, you should have the team split up in two scenarios. That means one team is sitting in a backend in the system and the one team is on the ground for you to look into all the details which has been required, and then there is a communication between both the teams and somebody approves. So when you have a full-fledged EMR systems, this is easier. If it is a manual system, this becomes a little challenging part. So we have to devise
Okay.
mechanism on doing it. The key
Okay.
elements which needs to be looked in for your live prescription audit has been stressed in the element itself. It's clearly given, listed out in the sixth edition.
And do we need to have a separate patient safety and a clinical safety officer, or there could be a
No,
dual
that
responsibility?
no, it is only one safety officer now. In fifth, we had two safety officers. That's been removed. So now we have only one safety officer. So you have to identify who is a safety officer. It can be a doctor or nurse or somebody who's having an entire knowledge on your patient safety aspects and other things. That is up to the organization. The concept of two patient safety officer has been removed in sixth edition. So one safety
Okay.
officer added is a medication safety officer.
So the medication safety officer could be a clinical pharmacist also?
It can be, because nowhere in the intent it has been specified the qualification, because if you see with the safety officer, little thing has been added. But in the NABH trainings, POS and other things, what the seniors have suggested is it can be a doctor, nurse or a pharmacist, provided he or she is having a complete knowledge of the medication management program. So
Okay.
that means he should be having knowledge in your pharmaceutical process. He should be having knowledge in your procurement process. He should be having knowledge in everything. So you need to have a person who has the complete knowledge on the medication program. So that means from the time of a procurement till it reaches the patients and post monitoring, he should have a knowledge on all the aspects. So that person qualifies it. It's good to go.
Perfect. And in utilization review, can clinical pathway be taken as an example?
Mm, can be, but here it is like it says that, see, for example, I'll say you one thing. PCAIR is a common surgery. So I'm looking utilization review in the length of stay. It is one thing is like, if I say length of stay, it is like, it is not like I'm achieving a target of 3 days or 4 days, which my organization has defined. It is like I'm looking into the resource it's been appropriately utilized. If a patient is going to stay for an extra 2 days or 5 days, that bed I'm not utilizing for a patient who is in a real need. So that is the concept of a bed utilizations and other things. So if I say some procedures which has been done, see, for example, this patient could have been done with their open approach. This can be done with your robotic approach. So that is again a utilization of the services what I have. So that means it is not about the cost which a patient is spending. So have I done a right approach to this patient in making a better service to that patient? So utilization looks on what we have and what we have done for the patients. So that means already I have defined something. Maybe if you say with the clinical protocol, pathways, I'm saying I have defined that what is that procedure for day one, day zero, day one, day two, day three, and what till my rehab. So if that has all been done, so it is already, I have defined some 50 steps, all 50 is happening. So that means it is appropriate. You can take it,
Okay.
but when you wanted to do something, definitely we need to have listed those measures to monitor it. But not only the pathway is ideal way. So if you say for pathway, because NABH asked only for two pathways, if I restrict only with two pathways, then I will be ignoring the other specialties. So we need to have it as a part of, we need to define the methodology for reviewing it. I can say that.
Wonderful. One last question. Okay, there is a question on prem and prom. So I would just like to inform the participants that we would be having a complete detailed session on prem and prom. I would take up this question. Ms. Anusha, would you like to highlight on patient support group?
Yes.
So who all can be the part of the support group, and is there a like a yearly planner that is required to what all activities a support group has to perform, or
That is what
how
I
it
said.
happens?
Yes. Patient support group is like a patient advisory. It is like a
Hmm.
patient advocacy. So it's like they are something like, you can't call them as a devil advocate. So as a patient, I know my pros and cons, how it is hard to be having. So that means I'm as a part. See, for example, I'm a patient advisor. Imagine I'm a patient cancer survivor support group is there. So I know the painful process which I have undergone through my chemotherapy, radiation therapy, or whatever the surgical management, whatever it is. So as a patient, I will know that if this all could have been changed, my experience could have been better. So that is what our support group is like. See, I'm a newly diagnosed cancer patient. So I'm with a lot of stress and agony. So is there somebody I can talk to them and get? It is like you can have your counselor in your organization, but it is like somebody who knows my process, somebody who has undergone the process which I am going to undergo. So that is what does a support group really means. I'm talking to a person who has really undergone all this process. I'm not talking to a person who is just a counselor trying to convince me with some beautiful words and English. So I want somebody who knows my pain already, or it is like simply somebody who can put myself into the other shoes and know that yes, this can happen. That is what is expected of a patient support group. An advisory
And
council is like they are part of the board. So I am a patient, I have undergone all these things. So I am part of it. So when you are making some patient care management processes and change and other things, these people are being empowered to suggest to your managements, and they are part of the committees whenever the decisions has been made upon. Even this patient advisory committees and other things, they all can be involved in some of the investigation processes of some things. That's all depends on your organization culture, how it goes in.
one question, Miss Anusha, I cannot skip because it's a painful question. Can we hire A&M nurses?
As per Indian law, it is now. We can hire in A&M nurses into your systems. You can have nursing assistants or some titles which is allowed in your systems, but you need to have a clear privilege of what they have to do. As per law, they cannot give you medications. They cannot assist for surgeries and other things. So you need to have a clear-cut, delineated privileges for them to say, this is my JD, this is what they are supposed to do. So that things is there, yes. But in audits, you cannot utilize them as a nurse patient ratio, you cannot account them. So with the current nursing crisis and challenges, you can have enough manpower to support the nurses in purely utilizing them for nursing care and other things, but they cannot be accounted for your nurse patient care ratios. They can be supporting nurses in delivering XYZ things. In what are the limitations they have, that has to be clearly defined.
Perfect. Thank you so much, Ms.
Thank you
Anusha.
so
It
much.
was a privilege to hear. I really got a lot of insights, and We would be looking forward to similar sessions with you in future. I request everybody to stay connected on the webinar threads. We would be continue to conduct similar sessions for all of you. And again, Miss Anusha, thank you so much for the insights and have a wonderful day ahead.
Yes,
Thank
thank you
you.
so much, Varun, for connecting me with initially and the team, Deepak, Vinodini, and Subhastri, who was there with me supporting for this process. It's really wonderful because in matter of time, we made it short and crisp, however it is possible. So always, I will say that your Bible or a Quran or Gita, whatever you believe, the book is on your table. Read back multiple times. Learning comes as much we talk, as much we read, as much we share. It is not the secrets between you and me. It is not the secrets between you and your colleagues. It is the written standards which everybody is up adapting. Keep learning, keep sharing. Definitely, we all will be staying connected in this tiny world, one or the other way.
Thank you so much. Madeline wishes all of you a happy learning. Thank you so much.
Thank you. Good day.